Luke, thank you so much for taking the time for a short discussion here at the Open Air Annual International Conference. Yesterday, you had a presentation about OneLondon, which is a project that is aiming to provide a single patient care record for 10 million people across London. I had an interview with Gary McAllister 2 years ago, and he explained a little bit about that, and I will definitely add that links to that discussion to the show notes. But let's start with the last 2 years since that interview took place. Is there anything that stands out to you in terms of what has happened with the project in the last 2 years? What were the key successes, and how is the project developing? Because I'm thinking, when this idea was initially formed in 2018, it was probably different to what it is now, because I'm assuming it's evolving. It's not a static thing.
Yeah, so thanks very much for inviting me. It's great to be there. I've really enjoyed the first day yesterday at the Open Air Conference, meeting some old friends and making new ones. It's a great community. And the opportunity to speak about what we're doing across London is important so that I can set out what we're trying to achieve, but also have challenges back. Right? I do accept the sort of the challenges that make us think in a different way. It's a really important part of the road to progress forward. And you're right to say that what we set out with 2018 and what we're doing now is different, and probably what our vision for the next steps are is different again. And it is one of the interesting observations that I tried to make yesterday in my talk, that whilst I think my concept and the concept of you have had as leaders is always about a data service, where do you start to build trust amongst your service community and with your public? And so the easiest step was to create an exchange mechanism across London to connect up London so that data could just be used at the point of care easily. And when I look at that over the last 2 years, that's sort of more than doubled its use over the last 2 years. Mm-hmm. And more areas are connected. You saw yesterday some of the areas beyond London and north of London are now connected into that each other thing. That goes from strength to strength, and that's a really important component part of the whole picture. When I look at the Open HR platform that we brought along with that 3.5 years ago now, the use of that for patients in their last few months of life has doubled in the last year. And we've sort of capturing about 3/4 of those people who it's known that they sort of may die. And that's a really great achievement. And we can report details on them very quickly. We've also, as of January this year, taken this first step for patients to have access to their record keys. So in England we have the NHS app, and we've plugged in these care plans now into the NHS app for patients can see them. From next year, patients will be able to request changes or initiate their own care plans, and that's another big step on that journey that we take. And I say the other 2 steps around that this year are that we've taken a different group of patients with sickle cell disease. And there are I think about 20,000 of those in England. The largest single group in London. They have a very 4D already, very specific prayer, in particular ethnic groups. And then about 3/4 of those in London now have their own care plans. Mm-hmm. So that's another important group. And the second bit is we'll extend that to further groups as we go through this year. So we keep extending the capability of the care planning. And it's actually, the concept is based on what some other countries do. I was over in Valencia in Spain a few years ago, and they had a very broad use care planning shield across their system. That was underpinned by contracts to health services there that were 10 or 15 years long. Rather than in this country, the contracts to health services tend to be annually renewable, so we have very different arrangements that we've got to work in a very different system. I think the other thing I would point out is this real issue about trust. Because you've got to be able to demonstrate to our diverse services and communities across London that what we're doing is safe and to make a difference to the care or make a difference to your life as a clinician. And we have good evidence that that's happening now, and that allows us to do some other things. So we've started to tackle in the last few months how we bring together people in crisis with mental health conditions, and how we have common approaches to the way we link those up across London. We're thinking and doing work around how we link urgent and emergency care together across London, and we're also thinking about how we extend this concept of a digital front door, so that the NHS app in London is a front door into all services, and through that we try and deliver some capability digitally and try and avoid some demand going through either primary care or secondary care or wherever as well. So they are sort of not delivered yet. The mental health one is close to delivering at the end of November. The first step will be delivered in the first couple of institutions, and the digital front door stuff next year. So it's all to play for.
The NHS app that you mentioned, is that specific for London or is that the national NHS
It's the
app?
national NHS app. in
Okay.
England, yeah.
Does it concern you in any way, the feedback that you are going to be getting from patients, and that it will become either confusing or that there would be too many requests for changes?
I think because we're trying to build it up slowly, and I think the key to this is to make sure that it's not a digital project or a data project really. It's a project where we need clinical leadership. And so for the end of life work, it was the physicians who were specialists in palliative care who took on the leadership of that project, designed the content and the forms that were needed, and then they worked with their patient first. So they're responsible for working with their patients to initiate that care plan. The patients with sickle cell, it's haematologists who are specialists in sickle cell disease, and there are, I think, 4 or 5 centres for that across London. Again, they're responsible for initiating that care plan. So where we have very engaged specialist clinicians, I think they're up for receiving the feedback from their patients and then putting that into a management process so you can over time improve things. If we were to open this up generally to all patients in one step, I think then we'd get a sort of bow wave of difficulty, which you may not be able to cope with. So we need to take a step at a time. This is I think this is a new thing for us in England.
Right.
And trying to get parity in the patient's, if you like, record, where the patients have to record it themselves, accepted. It is still an uphill battle, but if we take it a step at a time, I think we will get there.
Yeah. I kind of had the whole population of London in mind without really thinking that it's very
So
specific patient.
No, you're right. We're segmenting it
Yeah,
carefully, and then going to the next step. But the next few groups are, there's a category that we call living well. So how, if you've got frailty or recurrent chronic problems, you may have for 10 or 20 or 30 years, this group that are not going to get better, that we talked about some of the talks yesterday, how do we bring those people into this? So it's a bigger set of groups, and it does challenge some of the previous ways that you run and organise our services. So it'll be interesting to observe that.
How do you decide on which care plan is going to be the next one? Which patient group is going to be the next one that's going to get the care plans?
Okay, so now that we have some traction, we are getting more interest. So we have probably got 5 or 6 areas you would like their planning to be done through this tool across London. But you've got to think of what are the conditions for success. And what you want to do to define it as clearly as possible. So you've got agreement about what the content should be, and you've got agreement about who's going to clinically lead this. And that we're not too quickly opening this up too widely and too generally. So there is a sort of, in those organisations, those clinical networks who have asked for some support, we then have a sort of open process to try and prioritise what are the next steps. So we've got patients who are in crisis in mental health condition. We've got a big group the maternity is a big group where we need to share record more widely across London and help the patients. And if you think of those two, they may be very large numbers. So we need to think what's the next one we'll tackle. So that the way we'll decide that is having the clinical groups across London agree. If you can agree, and you will take responsibility, then we're likely to prioritise you more quickly than if you can't agree.
Okay. You mentioned the importance of trust, and one of the things that happened during the OneLondon project was the engagement of the public and really consulting them on their understanding of what they think they should see in single care record. It's something that France also did when they were creating their strategy. So first a research to see where people stand and how much do they understand. Can you explain that a little bit more? And are you still engaging with the public now to kind of keep up with that trust when you're rolling out new things?
So the first large-scale public deliberation, we call it, and it builds on work that some other countries have done. And we had an advisor from Canada, who's a world leader in this, came over in 2019 to help us with the first one. It also builds on, you remember the Irish government took a public deliberation around the rights and rules around abortion. And so we build on some of the things that some of the places have done, and some local council approaches in England and the UK have used this. So that first one was, we wanted to understand people's attitude towards how they expect us to use their data and for what purpose. So we weren't defining the contents of a record, but understanding what public attitudes were. And as I presented yesterday, very high compliance, high 90% expect us to use their data for improvement and expect us to use their data for research, and that's very welcoming. The subsequent deliberations, and we've run 4 in total, and we will run more every year to 18 months. We'll run a large deliberation now in London. Have taken us to a point where, we almost are receiving instructions from the public about what our next step should be and where they want to go. And they want more of this. The public want more of this. They want it in a safe and secure way. They want it in control. And we have a regular group of the public, a diverse group of public across London, who are helping us with some of this work and are pretty well engaged in this work, much more regularly now. So I think yes is the answer. We will continue it. I can't see us being successful if we don't do this. And it's a really important reflection for our clinical and organisational communities that the public have to have parity in the decision making.
Yeah, absolutely. There are several kind of projects inside OneLondon. We mentioned urgent care planning, universal care planning, transfer of care, and mental health. Given that mental health has become a huge kind of priority that needs to be addressed ever since the pandemic, can you explain a little bit more what you're trying to achieve on that level?
Yeah. So with all of these programs where we're trying to take a whole London approach, we've got to think about the sort of 3 or 4 things we need to be successful in to make the overall project a success. So the first, if I take mental health institutions across London, I think there are 8 different mental health institutions across London. And whilst to some extent they've worked on common protocols for care and support, they haven't previously collaborated on a single platform, so they have to use the same data, defined in the same way for the same purpose. So the first thing is getting them to collaborate in a way on the detail which they've not done before. And that's quite a big step. The second thing is then saying, what's the most acute problem where we think we can make a difference? Because mental health is a huge, broad spectrum of conditions and problems. And so what we've decided on is that there's a lot of liaison needed between mental health services, acute hospital services, primary care, the police, and social care. So this space is very unconstructed from a sort of digital flow piece of work. So we're trying to plug that gap, and we're starting with patients who may be sectioned against their own will, because we think, you know, the professional opinion is that they get threats out of themselves or to other people. And this is a group of patients who the care is fairly variable. They tend to wait either in police cells or in ordinary hospital AMEs for long times for decisions to be made. And the communication and sign-offs between the various permissions takes a long time, because it can be fax still, it can be email still, people have to be phoned up. So if we can join this to a single digital system and link it in to the shared record and the care planning tool, and we can sort of revolutionise this going forward. But it's just a first step. And it's really important that when we take the first step into a new area, you think very carefully about how we make those first steps a success. Because if we fail, we'll put back the journey a good few years. So we're going cautiously. But my hope for that is that if we can be successful in the next 12 months, and at the moment I think you will be successful, and we'll start to get into more complex areas. And I think mental health collaboration across London will build in a way it's not really built before. You know, there are some startling facts. So I've got two sons, and one of my sons is a policeman in London. And he tells me that when he was on the beat in London, although he was not doing that particular job anymore, half of the call-outs they had to were people who had some mental health condition. So the demand into other areas of society and other public services from this group of patients, through no fault of their own, is really huge. And so if we can improve the effectiveness of those services, then I think you start to relieve some pressure and deliver better care. And we've got to think of this in the sort of wider society terms that we're trying to drive. Because the police are also pressed for money and resources, and they struggle to cope with what they may say is not their priority isn't necessarily looking after people with mental health conditions. Their priority is treating the public safety, so they have different priorities.
Yeah.
We sometimes need to jump out of our space into a bigger construction of what we're trying to achieve socially.
Yeah. The connection of social care and healthcare is definitely an important one.
Yeah.
I always say that I love the Finnish approach, where they actually have healthcare and social care joined up in one ministry.
Yeah.
So you already, from that point on, kind of show that that's the two things that go together.
So it's interesting. I think we'd say now, probably in the second half of the pandemic, we did in this country bring social care into the Department of Health at ministry level. I'm not sure that has really effectively moved out into joining up services more effectively locally yet. So I think there's a long way to go.
Oh yeah, absolutely. And one of the things that you mentioned yesterday is that there's 24 different EHR systems across London. So it was a huge project to start to connect those. And what I'm actually wondering is, how is the move towards hospital at home, care at home, virtual wards, making your job even more complicated? Because there's new players, new entrants that are trying to cater to these needs, capture the data, and then they potentially bring in, new data models or new ways of structuring data that's not compatible to what you already have.
Yeah, so if you like, the virtual ward stroke remote monitoring journey, I'd say 20 years ago, there were some primary care services, some GPs who were offering what they call the hospital at home service, where on their GP system they'd have a list of patients who are looked after at home, and their community staff or a GP staff would be in touch or contact them regularly. So this has been going on in various guises for a long time. In the pandemic, the acute problem became, how do we decompress hospitals so we can admit patients to A&E more effectively and discharge patients? So who are the groups of patients we can discharge out of a hospital or stop getting into a hospital? And so a particular focus we brought on that group, and how the concept of virtual wards could support them. And as you say, at one point in London we had sort of 20 different suppliers. We're probably down to a smaller group now, And through the work you've done, you've tried to, over time, set some conditions into that work. So the data must be available either back into your hospital or GP electronic record, so we can then get to it through the shared record, or you must directly make this available to the shared record, and there are different mechanisms for different suppliers. The other bit of this is about how social care and local councils already have a lot of remote monitoring in people's homes, typically people who are frail. And so what we see is the people with frailty who are elderly and the people who have health conditions who need monitoring at healthy virtual mechanisms. The Venn diagram of those overlaps quite a lot. So what we see from a public point of view, public resource fund use, we're sort of doubling up resources and capability in those homes. So we have started in this work has started in southwest London, looking at whether we can combine our resources to have one approach that serves both purposes. And again, that's early. But as we build the platforms around OneLondon, we are applying conditions that try and reduce the number of suppliers, still allow some innovation to take place, but then make sure the data that's available is widely available at the point of need again. So that the principles that we have established over the last few years are followed. But it is complex, right? I wouldn't want to, and it's not perfect, you know. It's the story of all technology that you have a core of stuff, and then lots of things get bolted on, and then it becomes unmanageable. So you need to reconstruct it all so it becomes manageable again. And it's what we see, you know, software suppliers and technical suppliers will revise their products every few years, and that cycle's very shorter. And so it's the same with us. We are moving much more to a technology cycle of improvement than a sort of traditional health-driven improvement cycle, I would say.
And all that needs to be driven with consensus. What kind of stood out to me when you were talking is with universal care plans that you need professionals to agree on how they want to move this forward, which can be very difficult. But at the same time, I guess it's the only way forward. And if we just look from a little bit further in to the broader picture in the UK, I find it as a very interesting example where this realization, where you came to this realization that kind of doubling down on the number of decision makers is what makes sense. So the UK went from 200 commissioning groups to 42 integrated care systems, and OneLondon specifically then further kind of doubles down on 5 integrated care systems. So generally speaking, it's in the public interest, and it's very easy to understand that as patients we want, you know, to have our data connected in our regions or on national levels. It's much more difficult to actually put that in practice. So how do you see the approach that the UK took, and what maybe, I don't know, other leaders could learn from that? Or if there's any other examples that kind of stand out to you in Europe, you can also mention those.
Yeah, so I think there are some other examples in Spain, in the Nordics, that I would cite are good examples of at scale, because I think scale is a really important part that we need not to exclude from this conversation, of how you bring communities together with common aims to deliver something in common that benefits both the way the service runs and the treatment patients and the public get, but also from the public's point of view that benefits them as well, because both communities have to see the benefit of this to be successful. At one level, following the 2012 Health and Care Act in England, there was a splitting up into 32 different commissioning groups in London. And that was very difficult to try and have a consistent set of approach from. And at that point, we were trying to work with the who was willing to collaborate. You know, it may only on some things it may only have been a third of them. And as we've reconstructed the way health services are organised in England into the 42 integrated care systems, then I think that has helped. But it's still very early in that journey. Because even with an integrated care system, they've still got so many GP practices, so many hospitals that are all their own businesses, all their own entities, and all have their own decision-making capability. So what is it that makes people collaborate at scale? and look outwardly to a greater extent than look inwardly to a greater extent. And that can only be how you bring benefits, either benefit in the use of resources and efficiency, benefits in care and outcomes for patients, or benefits that the public want, and are strongly advocating for that. So what we had to do is take some sort of brave steps, I would say, and bring the public together. Because when we brought the public together in 2019, that was the first, I would say that's a world class in terms of scale and outputs deliberation that gave us almost a different political access to have a conversation with our local service to say, whatever you think in your hospital or your practice, your public want this to happen, and here's the evidence that your public want it to happen. So it meant we could have a different way of having that conversation with services and really shine a light on previous decision making. Mm. We then get, over the last 5 years, there has been I suppose, a resource constraint in terms of money, and that's probably helpful because it means people have to think, how can we share more and do more collaboratively? With less money and get bigger benefit. So I'm not sure a land of plenty is where we need to be, because I think that does drive lots and lots of individual decisions. And then the third thing is, I suppose, we've tried very hard to bring together our 5 integrated care systems with a regular set of discussions. So we converge on our strategic and delivery plans over time and understand the problems. That, my job as a leader is not to impose. My job is to support and bring people along and to understand the problems and try and help them work through them. I don't really believe in leadership by performance management. I sort of believe in leadership by collaboration and understanding and trying to serve as best I can, if that makes sense.
Yeah, it absolutely makes sense. There's, I assume, higher chances of success if you actually try to listen to people instead of directing them what they need to do.
You'd hope, but it's a long journey, right? It's not.
Yeah. It's a big job. Luke, we have to go back to the conference. It's day 2 today, so thank you so much for taking the time, and I think we definitely should continue the discussion. There's like a lot of additional questions that I could have.
Again, thank you very much. You've been very kind to me, and I'm enjoying the conference. I'm enjoyed today, and I wish you well for yourself.
Thank you.